I'm not going to go into what would be almost a hour-long presentation of Larry's many accomplishments. I just want to highlight the fact that in many ways, as I arrived here a little over 4 years ago, it became clear that Larry was the soul and conscience of our section. He has really had an impact from days when he was a resident here at Yale New Haven Hospital. He took a short sojourn to UT Southwestern, but returned to us and in many roles, including as chief of cardiovascular medicine, really initiated building the section that we are part of now. Along the way, Dr. Cohen has played not only important roles in the university, but nationally as, for example, president of the Association of University Cardiologists, as well as the Interurban Club, and many other kind of roles of leadership and impact. He has also had a huge effect on our on how we relate to each other. So it is, I think, wonderful to actually start seeing people in the room in honor of Larry as we kind of transition back to some new normal of hybrid environment for our grand rounds. And so, you know, my thanks to Dr. Cohen, to his wonderful wife, Jane Cohen, his family, who and his daughters who are here, for sharing Larry with us over these many years, and we hope to see him 2 to 3 times a week in the office suite, where it's a highlight of my day when we pass each other and can just pat each other on the back and know that we represent a lineage of excellence here at Yale. With that, I'm going to ask Rohan to step up, and I've been very excited to have a good friend, Dr. DeLemos, here with us to present this first Giants in Cardiovascular Medicine lectureship in honor of Dr. Cohen. Introduction.
Thanks, Eric, and it's great to be here, not only at the start of the Grand Round season this year and having people back in the auditorium, but to do it at for such an important occasion in the honor of Dr. Cohen. And it's for me, it's such a great experience to have Dr. DeLemos visiting here. James has been a mentor, a friend, a guide, a sponsor, you know, a teacher of the highest magnitude. Half of the science I do, the quality and the experience I bring to an interest in science in itself derives entirely from James. I can go on about his really storied CV, his background when he went to medical school at Harvard Medical School, came back to residency at UT Southwestern, did his chief residency there before going back to Boston for his fellowship at Brigham and Women's Hospital. He's currently professor and endowed chair at UT Southwestern, and is the anchor of the entire cardiology section, as well as of the cardiology fellowship program. This will not come as a surprise to him that James is the reason many of us went to UT Southwestern to pursue our clinical training. And it was always us looking up our schedule in April when it was released for the next year, if you got to do CCU with James DeLemos. So that was one of the experiences that defined my fellowship. And I think, you know, his accomplishments in science are too numerous to name, but he's done you know, remarkable work in biomarkers, risk prediction, and outcomes research, and more importantly, led important organizational aspects of ACC and AHA throughout the past couple of decades. And it has been just great to see everything mature in a way that we now use high sensitivity troponin for clinical use here at Yale. And James led some of the more important transformative work that led to its use in clinical practice. And then finally, you know, he's taken over the role over the last 7 years now as the executive editor at Circulation. And Joe Hill and Darren McGuire would say for sure that he keeps the journal moving, even with hundreds and thousands of submissions that they have had to handle. And it is a distinct honor for me to have James be here with us today and to share his words for an hour, which I was lucky to have for 4 years. Thank you.
Well, thanks to Eric and Rohan for having me, and really special for me to follow Rohan. I'd say that of the fellows we've trained over the years and that I've had some small role in mentoring, won't surprise any of you to know that Rohan had needed less mentoring than anybody we ever trained. He came to our place with skills. He made us better in every way, and I know he's doing the same thing here as a faculty member with you all. It's almost hard for me to put into words how meaningful it is for me to give a lectureship in honor of Larry, both for myself personally, but also representing our institution, because Larry is a critical tether between UT Southwestern and Yale. We had him first. He was part of the dream team at the NIH in the late 60s, working with people like Braunwald and Bill Roberts and Morrow and other people that, for the young people, if you haven't read about that period at NIH, read about it. It's nothing short of breathtaking. Nothing's been seen before or after in terms of accomplishments by giants in cardiology. And that was well before he was a giant at UT Southwestern or at Yale. When Larry left the NIH in 1968, he came to UT Southwestern to be chief of cardiology together with somebody that turned out to be one of his best lifelong friends, this individual, Jerry Mitchell. If I can get Jerry's here on the left. And this in the middle is Darren McGuire, who all of you know. And this probably says as much about Larry as anything, that they were chiefs together. How great would that be to be chief of cardiology together in a growing institution with somebody that's a great friend? I think that says much about the way Larry integrates work, family, and relationships. This is how I got to know Larry. This is an organization that Eric mentioned called the Association of University Cardiologists, that Larry's a legend in that organization. Jeff, he was president there, Larry was president. This is a picture of UT Southwestern alums in the organization, which have a pleasure to be a member of. And what you can see is after 50 years away from UT Southwestern, here Larry is taking a picture with all the UT Southwestern alums, just highlighting really what he has meant to our institution over all these years he's been gone, really in large part through his tether with Jerry Mitchell, who he was co-chiefs with. And then finally, for me, I met Larry at a point in his career where my relationship, and I would say the other relationships of people at UT Southwestern are driven equally by Larry and Jane. Individual powerhouses as a couple together, I've never seen anything like it, just in terms of their ability to make people feel valued. And Rohan and I were walking back, we were talking about last night, I think the word I would use to describe them is present. You can be in a room with either one of them or both of them, and there can be noise all around you. And when you speak for 2 minutes with them, they give you their undivided attention, their complete interest. They're fascinated by people, and it's empowering, and it's a great example for all of us. So to me, it's actually a little emotional to speak on your behalf, Larry, because even though we've only known each other for 10 or 15 years, the impact that you've had on me is really remarkable, as well as Jane. So let me get to some science. So what I'd like to talk about today is a journey of trying to use biomarkers to move towards precision or personalized medicine. It's not all a positive journey, but I think in the end, hopefully, we've seen some path forward. I've got a number of disclosures related to work I do in the biomarker diagnostic field, or DSMBs I sit on, that may have indirect relationships to some of what I'll talk about. But many of us will remember 2015 when President Obama launched with great fanfare the Precision Medicine Initiative, recognizing that doctors have always recognized that every patient's unique. They've tried to tailor their treatments to individuals. We match blood transfusions to individual characteristics of the donor and recipient. And he asked the question, what if we had the tools available to do this for all diseases? And the question is, in the 8 years since he launched the initiative, where are we with cardiovascular precision medicine? What we're looking for are tools, whether they be diagnostic tools, protein biomarkers, imaging, that provide direct insight into the underlying pathophysiology of the diseases we're interested in that directly inform treatment. We have a couple of examples, and I think it's fitting that Dr. Cohen participated in these trials that led to these examples. The best example, in my view, in cardiovascular medicine is the 12-lead EKG in patients with chest pain. When we see ST segment elevation, we know that the patient has complete occlusion of an epicardial coronary artery, indicative of transmural ischemia, and we leverage that information based on trials that Larry and the dream teamers from the NIH put together in the TIMI group to know that immediate reperfusion changes mortality and improves outcomes. The flip side, and why this is such a powerful personalized medicine tool, is that in the absence of ST elevation, not only does fibrinolytic therapy not help, but Larry and his investigators demonstrated that patients could be harmed. So this is exactly what we're looking for. We use it without thinking about it every day in 2022. But the question is, what beyond that? Are there other examples? Are there other places that we can move this paradigm forward? Unfortunately, the current state is all too frequently not the 12-lead EKG in the emergency room. Typically, we apply average treatment effects from randomized controlled trials or guideline recommendations and end up treating most patients the same based on our clinical judgment, which I still argue is very important, following the clinical course of the patient and their response to therapy, and is highly empiric. When we use tools, they tend to be relatively crude instruments to assess outcome probabilities, things like the CHADS-2 VAS score. And we then use these relatively crude tools to apply therapies that we know work to the patients at highest risk so that we can maximize either the risk benefit or the cost benefit of these therapies. A couple of years ago, one of our fellows, Kershaw Patel, gave a lecture to our faculty that we turned into a thought piece for circulation, really recognizing just how great the need is for tools in the modern era. If you think about where we are for an individual that leaves the hospital after myocardial infarction in 2022, we now have evidence from randomized controlled trials targeting multiple different pathways, including lipoproteins, inflammation, metabolism, platelets, coagulation, all of which have randomized controlled trials in the modern era demonstrating incremental benefit on top of the rally pack of therapies that you and we use to treat these patients. And the challenge, of course, is how are we going to decide which of these complementary, sometimes competitive therapies we should layer on top of standard therapies? And there are, as I mentioned in the middle here, therapies that have been demonstrated to be beneficial. And what we did here about 4 years ago was just guess at some of the tools that might be available. Some of them would be sophisticated biomarkers. Others might be simple things like history of polyvascular disease. But the point really in the piece is that we are desperately behind with regard to these tools to help guide the therapy. We know many of these therapies work. We have the need, but we have very little objective evidence in terms of how to target these therapies and how to choose other than our personal preferences among which of these therapies might be beneficial to which patients. So why have we struggled so much in cardiology? One of the challenges is that the risk assessment tools that we typically use are relatively crude. Things like the pooled cohort equations or the CHADS-2 VAS score are simple, but they're very crude, and their performance is marginal. We tout them, we use them, but when assessed objectively, the performance of many of our risk assessment tools is modest. The second thing is that for reasons, some good, some bad, we tend to focus on broad composite outcomes in cardiology, but the composites may reflect heterogeneous pathophysiology, the factors that contribute to cardiovascular death, myocardial infarction, stroke. They may all differ. And when we consider these composites together rather than disease progression metrics, we may get misleading information. The other challenge is that many of the tools that we have and explore don't reflect the disease pathophysiology. We have a disadvantage relative to our oncology colleagues that we don't have ready access to the tissue of interest. And from my standpoint, we'll talk mostly about biomarkers. Too often the circulating proteome that we're interested in doesn't reflect the target of interest. And an example, and Peter Libby was instrumental in helping me understand this many years ago, is what we're most interested in from the atherosclerosis standpoint are biomarkers that reflect pathways like plaque inflammation, proliferation, nitric oxide signaling, for example. And Peter made the point years ago that it's almost preposterous to think that we can detect in the plasma a signal from something as small as atherosclerotic plaque that we can distinguish from the large sources of these proteins in blood. And the dominant sources of these are the liver and big organs like the heart. And so when we think about what we can actually discriminate in circulating blood, it's really liver-related lipoproteins, and it's the effluent of large organs like the heart. That doesn't mean they're not useful, but it's highly unlikely that we can detect a direct signal from atherosclerosis. It's not impossible, but to date, and our group has spent many failed years trying to discover and validate atherosclerotic plaque markers. And I think Peter was right when he warned me 20 years ago that that was an inherently futile concept. So if we can't always reflect the organ of interest, we can't get tissue from our organs, and we're operating in sort of a relatively crude era. What baby steps can we make towards improving and refining risk assessment, and how might that help move us towards a more personalized and more precision-like approach? And I think it's important to recognize that risk assessment is front and center already in decisions that we make. Obviously, with regard to lipid-lowering therapy, we focus heavily on the pooled cohort equations to make decisions about who to allocate statin therapy for in primary prevention. But increasingly, as new lipid-lowering therapies enter the market, we're going to be using risk assessment tools to determine who gets something on top of statin therapy, including PCSK9 inhibitors, who might be individuals that might be candidates for add-on therapies targeting alternative lipoproteins. I think less well recognized is that actuarial risk assessment is front and center in the hypertension guidelines. This doesn't get talked about as much, but if you look at individuals with stage 1 hypertension in the new blood pressure guidelines, the massive number of individuals you and I see in the office with blood pressures between 130 and 139 over 80 to 89, it's recommended that those individuals undergo a clinical risk assessment with the pooled cohort equations. And that result is what drives whether they get drug therapy or lifestyle initially. And that has not received as much attention. I'd argue that because the effects of blood pressure lowering in this range are largely on stroke and heart failure, that using an ASCVD model may not be the optimal way to go. And I'll talk a little bit about that later. So risk assessment is front and center in prevention for our thoughts about who gets lipid-lowering therapy and who gets blood pressure therapy. But the problem is that the models that we're using don't work well enough. And given the massive public health implications of allocating these therapies, that's a major issue. This is data from quite some time ago using the old Framingham risk equations, but demonstrating that on the left, the pie chart, that the majority of US adults categorize at low risk, with smaller numbers at intermediate or high risk. But when you look at the aggregate number of events that occur in the population, the aggregate number of events back then that occurred among individuals that would have been characterized with risk factor models as intermediate or low risk is actually higher than the high risk. That's not because the risk equations don't work, but because their performance is highly imperfect, and because the number of individuals at lower intermediate risk is so large. But I would make a case for today that anybody that gets characterized as low risk with a risk equation and does not get treated on that basis is a failure of prediction, and therefore a failure of possible prevention. So trying to identify these individuals at low risk who actually go on to develop heart disease is a major objective of risk assessment algorithms. Of course, everybody focuses on intermediate risk and reclassifying them one way or the other. But I think the future is really targeted more towards apparently low risk individuals as we think about extending high quality life into longer years. When you look at how well the pooled cohort equations work, the performance is modest. I won't do a lot of statistics today, but the metric that we use to assess risk equations, the C statistic, or the area under the RC curve, for these equations is only in the 0.7 range, and in some replication series as low as 0.6. So only modest discrimination. And then when you get beyond that, probably a metric that's even more important is calibration. How well does the observed event rate align with the predicted event rate from the equation? And Paul Ridker, immediately when the pooled cohort equations came out, published these analyses demonstrating substantial overestimation of risk with these equations at low risk, both in women and in men. At the time, many of us argued, what's the problem? If you overestimate risk in the population and you end up over-treating individuals with statins, and at least in an auditorium like this, in which 99% of people will vouch for the benefit of statins in primary prevention, it might not be a big deal if the risk equations aren't calibrated. But if you're talking about adding a second or a third drug for somebody with hypertension, if you're talking about allocating therapies that might cost $4,000 or $5,000 a year, when we think about triglyceride lowering therapies or PCSK9 inhibitors for primary prevention, then the accuracy of risk assessment takes on a much more important implications for the future. So calibration ends up being an important limitation of the equations. The second argument I'd make about the challenges and problems with what we're doing now is that the maniacal focus on atherosclerotic disease is at best incomplete. You know, we're victims of our own success. People with atherosclerotic disease live longer, and they live longer with existing underlying atherosclerotic and structural heart disease. We may not appreciate this, but heart failure is already more common than coronary disease and stroke among the elderly. And while coronary disease rates are flat, heart failure continues to incidence and prevalence increases inexorably. And AFib is another major consideration. The lifetime risk is 25%, and the prevalence is projected to increase 2 or 3-fold. So, you know, in our view, the importance of risk prediction has to extend beyond atherosclerotic disease to also include heart failure and atrial fibrillation. And when we think about population health management and individual prevention both, we think these endpoints are important. So the question is, I didn't spend a lot of time on it, I will tell you that we have almost exclusively failed in our original goal, which was to find biomarkers that do what the EKG did with the work that Larry did. If we have been unable to find biomarkers that provide direct insights into the pathophysiology of disease that we can leverage for specific therapeutic decisions. But maybe, and I'll keep coming back to this, maybe we can still use these biomarkers to provide more precise risk estimation for prevention and public and population health decisions. So in the prevention office, this might mean taking, you know, the world of people that we might treat and allocating a smaller number of them to treat, not with inexpensive drugs with statins, but with some of the next generation preventive medicines. But I'll argue that for health systems like Yale and UT Southwestern, that the future of high-risk prevention led by cardiovascular specialists and maybe endocrinologists might take similar approaches on a population health basis. You know, we think about, Rohan and I have worked in a health system, Parkland, which provides complete care and capitated care for a largely indigent population. If we were able to identify which of those individuals are the ones that come back 20 years later and fill the hospital with heart failure, and we could target those individuals 20 years earlier for intensive heart failure prevention regimens, we might be able to use simple tools and biomarkers for a population health-like approach to really prevent disease in populations. Works obviously better in a capitated healthcare model. So the candidates to do this include genetics, biomarkers, and imaging. I don't do genetics. You all have many people that are more expert. I'll say that until recently, I've been fairly negative about the role of genetics for population health management and precision medicine. I do think with the advent of the polygenic risk scores that genetics at least enters the discussion, but candidly, I don't think at this point it does any more than enter the discussion for how we might use it on a population health basis or even in the prevention clinic to drive these decisions, because there's a lot more work that needs to be done across different ethnicities, and people tend to focus on the very extreme levels of polygenic risk, which exaggerates the relative value of these as risk predictive tools. But let's talk about biomarkers, and let's start with C-reactive protein, the prototype biomarker. And we're going to, when you look at the data, this is probably only visible on Zoom, but if you look from the back of the room, it looks like a scatter shot of, this is about 54 studies, 160,000 individuals, and 7,000 outcomes from John Dinesh's meta-analysis. And the point of this is that the findings are generally consistent in primary prevention studies. That tripling of CRP consistently is associated with about a 1.3 adjusted hazard ratio for future atherosclerotic events. So it's a true and replicable observation, good science, that CRP associates with increased risk. But for the challenge that we have in the prevention office, or I would argue and from a population health standpoint, that the major limitation is that the magnitude of association is quantitatively small. So a 1.3 adjusted hazard doesn't move the needle when you or I are seeing somebody in the office with a predicted risk of 3%. If we move them from 3 to 4% or 3 to 2.5%, that doesn't really change the decisions that we're going to make in prevention. And as a result, more sophisticated measures of risk reclassification, discrimination don't improve much with CRP. It's a true and replicable finding, but as a standalone test, it's not robust enough to move the needle with risk prediction. Now, one could make the argument, again, we've been looking for these trigger tools, and Paul would have argued, I think, years ago that this might have been a trigger tool, a biomarker that reflects inflammation. We have therapies that might have pleiotropic effects on inflammation, for example, statin therapy. And the argument a decade ago was that this was what we were looking for. This was a protein marker that informed pathophysiology that we could exploit. The challenge is that the qualitative interactions that we're looking for don't exist. And if you look here, this is data from rosuvastatin versus placebo in Jupiter trial, and looking at the relative benefit of rosuvastatin over placebo in primary prevention as a function of CRP. Now, remember, in this trial, they didn't enroll low CRP individuals, but if the hypothesis were true that this biomarker of inflammation predicted the benefit of, one would expect a qualitative interaction by which the benefit would increase over the CRP levels in the trials. You don't see this. If anything, there's a decrement. Now, the absolute benefit is larger in people with higher CRPs because they're at higher risk, but this largely refutes the idea that there's some sort of magical bullet, if you will, where the biomarker can tell you the pathophysiology that we can exploit. And that ends up being, if you see it, just for the young people, if you see qualitative interactions where somebody reports that a biomarker predicts the benefit of a drug, ask for replication, because in my experience, including my own work, these things have just not replicated. The flip side, and I'll come back to this, is that there are quantitative interactions, and that's what we're going to, I think, in the future will exploit. So CRP is a replicable biomarker, not particularly strong quantitatively. But what about more specific cardiac biomarkers? So we've spent a great deal of time working on natriuretic peptides, B-type natriuretic peptide and NT-proBNP. This is data from our Dallas Heart study. It's a large population-based study in which we did MRIs in about 3,500 healthy individuals in the population. And you can see here that, sorry, I can't see the pointer on the bottom, which is why I'm, so if you look at levels of NT-proBNP and across the proportion of individuals that had MRI-determined LVH or systolic dysfunction, very striking associations. It won't surprise any of the cardiologists that there are strong associations with cardiac structural abnormalities. Also, though, interestingly, there are associations with atherosclerosis. This is the association with the coronary calcium scan. And even after you adjust for all of the determinants of natriuretic peptides and coronary calcium, there's a modest association with atherosclerosis burden and higher NT-proBNP. So at first glance, much less promiscuous marker. It's made in the heart, associates with atherosclerosis and with structural abnormalities. This might represent a more cardiac specific tool for population screening. And in fact, that's been observed. These are data from another Oxford-based meta-analysis looking at NT-proBNP and the outcomes in population-based studies, includes our Dallas Heart study, about 100,000 individuals. I think if you look at NT-proBNP for coronary heart disease, you can see that there's an exponential relationship that's moderately robust. You get adjusted hazards at high levels of about 2, remember we were talking about 1.3 for CRP. I think importantly, if you want to reference it, it looks almost exactly the same as HDL, which is obviously included in the pooled cohort equation. So it's a pretty good marker for atherosclerotic events. Of course, it's a great marker for heart failure events. If you look at the association on a quantitative basis, even at relatively low levels in the population, incident heart failure goes up strongly and much more strongly than HDL. So NT-proBNP, at least as good as HDL, much better than CRP for atherosclerosis prediction in the population, but a really powerful marker for heart failure. What about biomarkers of cardiac injury? This is the area that our group has worked on in the last 10 years. And in 2010, we published 3 studies essentially at the same time from 3 large population-based studies. Our Dallas Heart Study, which was adults in Dallas with a high proportion of women and African-American individuals aged 30 to 65. The Cardiovascular Health Study, which was led by Chris DiFilippo, older individuals, and the atherosclerosis risk in communities, which was a middle-aged population and the largest of these. In the Dallas Heart Study, the proportion of apparently healthy individuals who had detectable high sensitivity troponin T was 1/4. In the older populations of ERIC in the Cardiovascular Health Study, it was about 2/3. So even in the absence of known cardiovascular disease, depending on your age, between 1/4 and 2/3 of apparently healthy adults walk around with troponin levels that are measurable. And this is with an assay that has been replaced by even more sensitive assays. And the obvious question is, what does this mean? And what we did is we modeled in the Dallas Heart Study the determinants of cardiac troponin in the population. And identified male sex, older age, diabetes, worsening kidney function, and then multiple determinants of cardiac structural abnormalities, greater LV mass, LV end diastolic volume, wall thickness, hypertension. Equally important is what we didn't observe. We saw no associations, and I should have said the Dallas Heart Study did include, it was a population-based study, so there were a few individuals with prior disease, but none of the atherosclerotic variables independently associated with troponin. And so this was really the recognition that while we measure troponin in the emergency room as a heart attack marker to give insight into the coronary arteries, and in point of fact, it has nothing to do with the coronaries. It's a muscle marker in the heart. And when you measure it in people without coronary symptoms, it's reflecting largely structural abnormalities in the heart and other comorbidities that may influence troponin levels. The next question was, what does this mean in terms of long-term outcomes? And this is the Dallas Heart Study. We divided the group into the 75% with undetectable levels, the levels that were above what they would have been considered the 99th percentile, and then tertiles in between. And I want to emphasize, this is not a population with heart disease. This is a general population sample. In this group of individuals, over just 6 years, 30% mortality rate in a stepwise increase. So a clear signal that this phenotype that we coined shortly thereafter is chronic myocardial injury, the idea that you might have evidence of an injury marker troponin in ambulatory living might have prognostic implications. Now, ERIC was the largest of the studies and allowed us to look at the cause-specific outcomes associated with higher troponin. This is a cumulative distribution plot, higher troponin levels on the x-axis, and the outcomes of incident coronary disease, mortality, and heart failure shown here. I want to point out that there's a moderately strong association with coronary disease. And to put it in context, this is much stronger than you see with CRP. But this isn't really a coronary disease marker. It's a much stronger marker of incident heart failure, which really tracks with what we observed with the pathophysiology. It's associations with the phenotype of underlying structural heart disease then go on in the succeeding years and decades to predict individuals that will develop heart failure in the future. Now, the Cardiovascular Health Study had the advantage of a second troponin measurement performed 2 years later in about 3,000 individuals. And the next question we asked, are dynamic levels of troponin in the population informative? Because that might help us to identify whether the risk signal that we're seeing is modifiable. And on the x-axis in groups are the baseline levels. You can see that, that cardiovascular death increases as the baseline levels go up. But the point here is that no matter where you started, if your levels fell by 50% or more, risk was lower. If your levels increased by 50% or more, your risk is higher. And so, and this was independent of all standard risk variables, and we saw the identical association with heart failure. So this really raised the idea that if we could find therapies that promoted decreases in troponin in the population over time, or at least prevented increases, we might be able to modify the trajectory of future heart failure in the population. And that's really been where the work has gone in the last 10 years since these studies were published. And our group and many others have started with largely observational studies, which have all the limitations that you all are familiar with. But we generally have seen things like higher levels of physical activity and fitness and lower time spent in sedentary behaviors associating with more favorable troponin levels and more favorable trajectories over time. Lower hemoglobin A1C levels, even a decade before the troponin measurement, associates with a more favorable trajectory. Observational studies have suggested better blood pressure control. Jim Januzzi, who Eric was talking about last night, has observational and randomized data to suggest that things like SGLT2 inhibitors may modify the troponin trajectory. So limited data early, but much more work needs to be done. And I'll come back to this towards the end of the talk. So the next area that we wanted to address is if the biomarkers themselves can't be used for these yes/no triggers for therapies, can we use them to augment standard phenotyping to get better insight into disease phenotypes? And the area that we focused on was left ventricular hypertrophy. So these are data Ian Nealon from our group developed in the Dallas Heart Study using MRI definitions of left ventricular hypertrophy. In this case, in red, a group of individuals that had LVH with a measurable cardiac troponin T. And in the blue are LVH with a normal troponin T, and the other two groups have no LVH. And what we see here is that we can refine the phenotype of LVH, where the half of individuals that have detectable troponin, we've showed the same thing with BNP, are at markedly higher risk for incident heart failure. These are people in the population, again, a 25% risk of heart failure or cardiovascular death over 6 years. But the equally important feature is that LVH in the absence of biomarker abnormalities is benign. And this, we coined this term malignant LVH to reflect the future risk associated with this variant. Alana Lewis from our group, very interested in trying to disentangle racial disparities in future heart failure risk. And when we look at this malignant LVH phenotype, LVH by EKG, echo, MRI, associated with mildly abnormal troponin or BNP, the phenotype is dramatically overrepresented in Black men and Black women relative to white men and white women. I'll emphasize here that Black women have a higher prevalence than white men. And not commonly appreciated, in all of the population-based studies, Black women actually have a similar or higher risk of heart failure than white men, striking when you consider the much lower atherosclerotic risk profile. And so what Alana did next is look at the association of malignant LVH versus no LVH or benign LVH across race ethnic groups, and the risk association is similar. The risk is really exclusively limited to those individuals with LVH who have either abnormal troponin or BNP, but because this is so much more prevalent in African-American individuals, the population attributable risk is much higher. And so the next feature here is trying to go back and try to disentangle the largely social determinants that lead to this high prevalence of the intermediate phenotype, because we're hopeful that this phenotype may be at a phase where the disease is still modifiable and the future trajectory for heart failure can be addressed. So take home on cardiac biomarkers. With CRP, it arguably doesn't provide enough information as a standalone test to select candidates for prevention. It provides consistent but modest associations with risk. I didn't show these data, but it's very clearly not in the causal pathways leading from inflammation to cardiovascular disease. NT-proBNP and troponin are more promising. They predict heart failure and fatal disease to a greater extent than ASCVD, and they stratify LVH into benign and malignant phenotypes. I didn't talk about this, but the future in terms of massive aptamer-based and other arrays where you can measure 4,000 and 5,000 proteins open the door to larger scale discovery. In my view, the integration of high-level proteomics with genomics and Mendelian randomization, very promising for identifying drug targets, but yet not a single protein marker for clinical use has emerged from any of these wide-scale discovery tools. So the last sort of candidate for improving prediction and maybe moving towards a more individualized approach is imaging. Obviously, you all are, I'm sure, are doing a lot of coronary calcium scanning in your practice, and the rationale is really strong. These are data from Amit Kher and our group, highlighting basically in the Dallas Heart Study the very strong stratification of risk according to calcium score. So this, I want to point out, I'm a biomarker person, but the evidence for magnitude of association with calcium, certainly for atherosclerotic disease, dwarfs anything that we see with the protein biomarkers. So this is a biomarker that really works. The relative hazards across categories are large enough to dramatically move the needle in the office for prevention, and that's why this has emerged appropriately. When you look at coronary calcium scanning in intermediate risk individuals compared to other imaging techniques like intima-media thickness, ABI, flow-mediated dilation, you can see that the NRI values across multiple studies are dramatically higher for coronary calcium than they are for these other imaging tests, and dramatically better than for CRP. I'll point out in the one study that measured NT-proBNP for risk reclassification, NT-proBNP is in the same ballpark as calcium. So when we're sort of handicapping these tests, NT-proBNP ends up being the strongest of the biomarkers, followed by troponin, and they come close for certain endpoints to coronary calcium. So we had been interested, and we had support from NASA to try to build a Cadillac risk prediction tool. So NASA's interested in, as some of you know, flying to Mars. They've delayed that to go back to the moon, but when we got the grant, they were interested in flying middle-aged, mostly men, on a 3-year mission to Mars. And other than a mission catastrophe, the actual greatest threat to these middle-aged men would be a cardiovascular event in space. So they were interested in investing in tools that could allow them to help make better decisions about astronaut selection and flight clearance. And so we were able to work together with a great group to put together a lot of the information that many of us have been doing with risk prediction. And this led to the following study, where we used data from the Dallas Heart Study in Mesa at the baseline examination. We excluded anybody with prevalent disease. We measured the tests that I've already talked about, a 12-lead EKG for LVH, the blood biomarkers, and a CT for coronary calcium. We followed individuals not just for incident cardiovascular disease, because the AFib or heart failure in space would be equally devastating for the mission. And we call this endpoint global cardiovascular disease. That's, in our view, what our patients are also interested in when they come see us for a high-risk prevention visit, is not just atherosclerosis, but now there are some differences in the patient population. The DHS is a bit younger and has a higher proportion of African-American individuals, but otherwise both at-risk populations with a lot of ethnic diversity. And so when we look at the individual test results, so we measured 5 tests, EKG for LVH, calcium and pre-specified levels of the biomarkers. The prevalence of each abnormal test ranged from about 10 to 50% and differed between the DHS and MESA, reflective of the differences in the population. When we look at what these biomarkers do on top of standard risk models, so the base here is the pooled cohort equations that we started, and we highlighted their limitations. And in the Dallas Heart Study, when you adjust for the pooled cohort equation variables, each of these tests provides independent and incremental information, not just to the pooled cohort equations, but also to the other biomarkers. So 4 of the 5 were independently associated at a fairly substantial level, 1.5 to 1.6 at the threshold. And in MESA, which was a bit larger, actually all 5 tests provided independent predictive value, suggesting that these tests are reflecting non-redundant processes that may provide value for future risk. And when we look at what these mean, and we've done this in several different ways, but this is a simple integer score counting up the number of these simple tests that are abnormal in the general population. These are data from DHS, but they replicate in MESA. The message number 1 is that if you're one of the third of individuals that doesn't have any abnormal test results over a 10-year period, your risk of any cardiovascular event, atherosclerosis, heart failure, AFib, is extraordinarily low. And as you accumulate larger numbers of these test abnormalities, the unadjusted risk is 30 to 35-fold higher, but the adjusted hazard, meaning after accounting for what we're typically measuring in practice, is about 5.5. And when you get to adjusted hazards in this range, you start to get to a point where you're actually moving the needle in the office-based prevention practice. I think you're also moving the needle in terms of who should come to Yale and UT Southwestern for high-risk primary prevention, because you're actually moving people from not treat to treat categories or the other direction. When we look, this performs similarly well for global diseases. Atherosclerosis, I think importantly, seems to perform similarly for men and women across all ethnicities in younger individuals. And then I think where this would likely be targeted in people who were estimated to be at low risk with the pooled cohort equations, you see strong stratification of risk. These tests are not expensive, but they're not cheap. How this would be allocated, implemented, paid for are all very important questions for the future. The obvious immediate example is sort of the executive physical that some of us have participated in at our institutions over the years that typically include a lot of low value, high cost tests. I'd make a case that if that is to be done, these tests are lower cost, higher value because they provide more information, but where it might go beyond that's not clear. But beyond that, that's sort of the 101 level of how you might use these markers. The 201 level course is to recognize that each of these tests, as we talked about, have different underlying pathophysiological constructs and therefore predict different of the individual cardiac endpoints. If you look quantitatively at sort of the global outcome, NT-proBNP, calcium, troponin, and EKG look strong, but when you get at the individual endpoints, for example, coronary disease, not surprisingly, we found that coronary calcium was the strongest, NT-proBNP second, and CRP and EKG LVH provided nothing. For heart failure, it's NT-proBNP, troponin, and for death, NT-proBNP, troponin, and coronary calcium. So you can not only provide insight into global risk, but you can get insight by which of the markers is abnormal, potentially for cause-specific risk. Now, this is not precision medicine, right? But I would argue that could we move towards maybe the best we'll be able to do in the near term is precision-like prevention or population health, where we can use these biomarkers to identify which patients in our office might be at risk for AFib, or for example, coronary disease with the calcium scan and NT-proBNP, or heart failure, and that as good clinicians, we already know therapies that might prevent one or several of these outcomes. If it's AFib, we know that weight control and treating their sleep apnea may be particularly important. If it's heart failure, blood pressure control, thinking about SGLT2 inhibitors, et cetera, that we might be able to more intelligently target therapies that we already know work based on our clinical experience in clinical trials to the endpoints that we identify the patients at risk for. So we can identify what they're at risk for and think about more intelligently using therapies that work. So this is, it's not exactly precision medicine, but if you can match the biomarker with the endpoint of interest, it may be a step in the right direction. And Rohan's great friend Ambrish Pandey has led us in new directions, really taking all of this information and thinking about applying machine learning into some of the data sets. And what's interesting here is that the models that emerge in different ethnic groups emerge differently. But I'll point out that in the machine learning models, the biomarkers in both Black and white adults emerge very high, NT-proBNP and troponin, even when you throw sort of them into the kitchen sink with unbiased machine learning, that these markers end up emerging. But interestingly and importantly, the other things that emerge and may emerge differentially are social determinants of health. So it's naive to think for incident heart failure that the biomarkers are the whole story, but in the future, we may be measuring these clinically. We may be capturing social determinants of health from the electronic record, but other sources to provide a more individualized risk assessment for somebody's risk for heart failure. And that group of individuals may get targeted either in the community or referred for therapies that may prevent heart failure, which is so expensive. So I'll finish with really some thoughts about how these tests might be used clinically. A study that I love because it's straightforward and pragmatic is Stop Heart Failure. This was done in Ireland, in which they performed a BNP measurement among individuals in primary care. It randomized the group to either receive the information from the BNP or not to, and they were blinded. And then if with the BNP measurement, they received coaching for risk factor modification according to the BNP, and if their BNP was above 50, they underwent an echo. So the biomarker was used to guide the intensity of surveillance and testing. And what they observed, and it's a pilot study, was that the intervention arm had about a 50% lower risk of a composite outcome that included clinical heart failure, but also echo abnormalities. But that when you look at the group that had a higher BNP level, the absolute and relative magnitude was greater. And I like this, not because it's definitive proof that this works, it's a pilot study, but because this is probably how this would work in population health management, where we start, we measure BNP levels in the community. If they're low, we reassure the patient, give them counseling perhaps, but if it's higher, then those individuals may get elevated to another tier of prevention that may include an evaluation for structural heart disease, for example. We, Jarrett Berry and our group, got an R01 to evaluate how these biomarkers might help inform blood pressure treatment decisions. And we used Sprint. We measured troponin T with a high sensitivity assay and NT-proBNP in individuals from Sprint. And the reason we chose Sprint comes back to this idea that if we know how the therapy works and what the individuals are at risk for, we might be able to marry the biomarker and the treatment. If you recall, Sprint was a positive study demonstrating that pushing people to very low blood pressure targets was beneficial, but the benefit was on heart failure events and all-cause mortality. The same endpoints that we've just talked about are predicted by troponin and BNP. So it really didn't lower MI and surprisingly stroke. And so what we did is we measured, we asked the question, can we use the biomarkers to help inform the decision about who should be pushed to low levels? And it sounds, for those of us that work in the office, it's no trivial decision when somebody has a blood pressure of 135/82 to think about whether to add another agent. Often you're getting to agents that have lots of side effects. You're talking about inconvenience and expense. So once again, there's a failure and a success. The failure is we did not observe any difference in the treatment efficacy of intensive blood pressure therapy on a relative basis, whether troponin was abnormal or normal. So the relative hazard, the hazard ratio was the same. So the effect of the therapy was the same whether troponin was normal or abnormal. However, because troponin was such a powerful predictor of the risk for these endpoints, the number needed to treat, the absolute risk reduction was 5% over 5 years versus 2%, and the number needed to treat to prevent event was 20 versus 60. So you can arguably more efficiently target therapy to these higher risk individuals simply on actuarial risk assessment. The same story with NT-proBNP, and when you look at the combination, individuals that had both elevated, the absolute risk reduction is really striking in Sprint, almost 8% in the death and heart failure over 5 years, only need to treat 13 individuals with much higher NNTs for individuals with normal biomarker levels. The same story for mortality, all-cause mortality for individuals that have 2 or more biomarkers abnormal, treated to older targets versus newer targets, really, potentially meaningful differences. Now, one would argue that the implications, because all of these people are already on blood pressure therapy, are less robust. The other area that we've been exploring, and this is work led by Parag Joshi and Ambrish Pandey, is in that space that we started with. Remember that the blood pressure guidelines recommend risk assessment for this stage 1 hypertension group, with the less than 10% being recommended for non-pharmacologic therapy and the greater than 10% being recommended for pharmacologic therapy. We asked the question, since the biomarkers predict the endpoints that are affected by the blood pressure lowering, could the biomarkers do better than the pooled cohort equations? And so that was done here. And what Ambrish and Parag demonstrated here, let me go up one, was that if you look at the group that's currently not recommended for drug therapy, if they had abnormal biomarkers, the number needed to treat was dramatically lower than if they had normal biomarkers. And in fact, lower than the group recommended for treatment who had normal biomarkers. And so on a simple modeling and actuarial basis, we can more appropriately assign among the world of individuals who have blood pressures between 130 and 140, because you get a better actuarial risk assessment, you might more appropriately target therapies. Same sort of story for another therapy that we have to, difficult to allocate, PCSK9 inhibitors post-ACS. The TIMI group has demonstrated that if you are not recommended for PCSK9 inhibitor therapy based on lower risk, but your high sensitivity troponin is abnormal, you have an absolute risk reduction that's the same as if you were recommended based on very high risk and your troponin is low. So you can move people to different treatment decisions based on the levels of the biomarkers, not because they're telling us which drugs to use, but they're giving us better information about future risk. And then the last area that we've considered is applying these multimodality models for decisions like SGLT2 inhibitors for individuals with diabetes, which in our health systems we can probably afford, but maybe across the world a more difficult decision. And if you look at that multimodality score that we talk about, this has everything except coronary calcium. As that score goes up, the risk for heart failure goes up dramatically, and one can model basically the number needed to treat to prevent an incident heart failure event with SGLT2 inhibitors. If you have limited resources in your health system, you can apply this expensive therapy to those individuals that are most likely to benefit. For example, the high score group, which is only 10% of individuals, contains 40% of the events, and the high score meaning abnormal levels of all of the biomarkers in EKG LVH. So just preliminary data, just thinking about moving from sort of the in silico lab to implementation. How might we use this information? So to summarize, disease-specific, causal, modifiable cardiovascular biomarkers like Larry and his team demonstrated with the EKG 40 years ago have proven elusive. And if you see them, be skeptical. Qualitative interactions by biomarkers are rarely seen, and when they're seen, have tended not to replicate, like for CRP. But, and I didn't make this explicitly clear, that when we measure biomarkers that reflect existing but unrecognized subclinical disease, those seem to be the most powerful. They enhance actuarial risk assessment, and they allow us potentially to provide outcome-specific risk assessment, and that enhanced risk assessment that's more accurate, outcome specific, can be leveraged not for precision medicine, but what I'm test driving this term precision-like medicine in population health management. That may be the best we can do, because we can't directly, the biomarkers are too promiscuous for us to get specific pathophysiological information, but we can leverage what we can get to make better decisions, including individualized treatment choices regarding blood pressure, lipids, diabetes therapies, triage, which I think is a really powerful option for high-risk prevention clinics. And in an area I didn't talk about, but very useful for enrichment for clinical trials, because we can dial up, we can predict which endpoints and how often they're going to occur. We can enroll clinical trials with fewer individuals and reduce costs. So thank you all for your attention. Like I said, Larry, this is a career highlight for me to speak in your honor. So.
Thank you, James. And maybe we have a few minutes for questions. That was, just a tremendous. Thank you for educating us today. I figured I would first ask Dr. Cohen if he wants to ask the first question before we open it up to the larger group.
Thank you, Eric, and James. Thank you so much. We talked about millions of patients in clinical trials, and encapsulate the role of biomarkers. I have one specific question, and it deals with calcium score. Show that there's a relationship between increased calcium score and future cardiovascular event. My own concept is that the calcium score is a marker, and that probably is a marker of adjacent plaque. My question is, are there any studies that take patients with high calcium score, blind them, treat half of them with a statin, lower the LDL, presumably change the plaque, and possibly change the outcome? So my question is, has there been such a study?
Yeah, It's a great question, and I think that's the fundamental question with all of these tests is, and there will be people that study has not been done and completed. And the fundamental question is, do we need that study to drive a change in patient care? Because I think obviously that would be the highest level of evidence. I think that there is considerable risk in such a study being falsely negative. You know, and my view is that, you know, at least for decisions like statins, where we have so much information, and we already base that decision on actuarial risk assessment, that trial is not necessary to use calcium to drive this decision, because we already know that statins reduce events in people in that above a certain threshold of risk, that statins are the risk benefit and cost benefit is favorable, and coronary calcium does that. But the, you know, the cost implications and the size implications of the trial you're describing have made it difficult to get started. And I think the other piece of it, it's out of the range of an NIH study. There's no sponsor, pharmaceutical sponsor who would have any interest in that at this point. So, but that's where, you know, that's the debate is that level of evidence needed before we routinely recommend something like calcium scan. Jeff. Okay.
Thank you for being here. Spectacular lecture, and a perfect one in Larry's honor. I want to revisit the concept of what you described as personalized like treatment versus true personalized precision, or precision like versus precision medicine, and the fact that we all feel like we failed our quote unquote low risk patients at times. And this goes back to the thought about the true pathologic drivers of the disease, mechanistic pathologic drivers. And your description of risk marker profiles is brilliant. I think it's very helpful to understand whether we need to treat our patients more aggressively. But I would claim that if we understand the pathologic drivers better, we would be able to get closer to that personalized type, those approaches. So and coronary calcium is an example. I mean, there are people who have high CAC scores who are quote unquote low risk, and we don't know what's driving that. Maybe whatever's driving the coronary calcification is driving their clinical events as well. So the question is, how do we get at that? How do we do that? I mean, there are people in this room who are using genetic small animal models, and we can find this molecule, this gene, that gene, and we send the paper to you in circulation, it gets published, and then it sort of falls into the breeze, into the stratosphere somewhere. How do we really get at that?
Well, and great comment. So first, you know, we're just at the cusp of having therapies that directly, you know, address mechanisms, and we only, of course, know a few of those mechanisms. I think where I am optimistic about biomarker and disease validation in humans is work that people like Svati Shah and Rob Gerson are doing, triangulating genomics with high-level proteomics or metabolomics, lipidomics, to basically establish or try to establish, you know, that the biomarker associations may be reflective of causal mechanisms, because that's always the challenge. There's the challenge of translating the animal model to the human, and then there's the challenge with the biomarkers of understanding whether it's a bystander or has causal effect. But I think that approach to sort of take the world of potential targets and narrow that down into ones that are have a higher likelihood of successful translation to humans is among the things that I've seen the most promising. But and the other piece I would add to that is I also agree that you know, even though genetics and polygenic risk scores may not be ready yet, the idea that one could do that earlier in life, and you know, once we, particularly once we have a better understanding of the pathogenic mechanisms of some of the variants that we're identifying, I think the future is still very bright there. I don't mean to be nihilistic, just that we're not there yet.
Thank you. Maybe Arya and Bob, and then we'll close.
Great call. I want to about two areas. One is that you didn't mention anything about galectin-3, and I wonder if that's actually marker of remodeling hands out, especially risk stratification of patients with heart failure. And as a geneticist, I agree with you that polygenic risk score is not there yet for risk stratification, but there is some evidence that rare variants, such as FH, if you have it, even if you have equal amount of LDL, you are at higher risk because you're living with that since your childhood, and that would be of benefit actually to use that as a marker.
Yeah, I agree. Your second point, I completely agree. And we're probably headed for a time when our clinical patients will be genotyped in these rare, and that I think for FH, for cardiomyopathy, for arrhythmias. I mean, having, the challenge, of course, are the variants of unknown significance, but for the variants that we know what to do with, if we can figure out how to translate that, I completely agree. Galectin-3, of the next tier biomarkers after high sensitivity troponin and natriuretic peptides, I'd say that galectin-3 is among the candidates. I've been a little disappointed. It is highly promiscuous in terms of its cell sources, and the data are not completely consistent. I guess I know it's approved and some people are using it. I'm skeptical that it will stay the test of time. It's been touted as a fibrosis marker, and that's one component of what drives it, but there are so many others that it can't be used that way clinically, in my opinion.
Hi, James. It's great to see you. This is an excellent presentation and a very well thought out, logical approach for dealing with patients, even right now. My question has to do with, is anybody in your group looking at the cost effectiveness of all of this? I mean, it's all great to look at this, but it's very different in the clinic if you're dealing with some of the systolic blood pressure of 135, of whether to increase your, ACE inhibitor or lisinopril from 10 to 20 or something like that. Than to add one of these new medications or everything, because obviously these tests are not that expensive on an individual level, but are hugely expensive on a population level.
Yeah, great question. I mean, yeah, we have some, not explicitly looking at it. We need to consider that, and that comes up in every paper we write. I guess part of me pushes back a little bit. The biomarkers are no more expensive than the chloride and the bicarbonate that the ChemSet, if you think about, if the model changes, right, and you say, okay, I would say that of the people that come in and get annual lab testing, which for people that have good medical care is the majority of individuals, I would just make the case that the information from an NT-proBNP and high sensitivity troponin, both in terms of useful information and actionable information, is more useful than anything besides a potassium and a creatinine already, right? And we don't question whether a creatinine or a potassium is sort of cost effective. You're $12 to $25 a test if you did it sort of once a year. I think that's sort of the model change, is thinking about, well, what constitutes useful laboratory testing for a routine examination that Medicare would pay for, or something like that. It's sort of outside of my scope, but I think that's the discussion. I think we already know that it provides more value than many of the other tests, than the routine platelet counts and CBC and things like that we're spending money on already. Now, the calcium scan and the EKG are a little more challenging, because those are tests that require different workflows to get done and more expense. And I think it's a valid construct. I happen to think calcium scanning should be applied to lower risk individuals. I think at a certain age, as I think about sort of what Larry's point, and I think that this focus on intermediate risk is a little misguided. And I think that really what we're interested in is, and as Jeffrey said, is this identifying falsely low risk, and that's really applied at a certain age to more broadly. And again, it's only, if we decided to pay for it, it would be under $100 a test or something like that.
Yeah, maybe one. I'll ask the last question, and then which is, can you tell us a little bit? So much is coming out of Dallas currently around the polypill strategy, and how do you envision integrating this wonderful work you've been doing over the last decade at Dallas on biomarkers with a polypill? Are they at odds, or is there a way to integrate them?
Yeah, that's a great question. Sort of at the obvious level, the polypill is the antithesis of personalized or precision medicine. But the question is, how do you select who should get the poly pill, right? And that's you know, and it's going to be based on actuarial risk assessment. So the idea is that you would target the components that you know lower risk and apply it to people ideally with better assessment of risk. Now, again, obviously that in that context, the cost it has to be considered. But I think that would be, you know, and you know, if we're thinking about a poly pill, that all has to do with not just the cost of the poly pill, but the you know, the side effects and safety concerns of the individual components. But I happen to think that a poly pill for heart failure prevention would make great sense, but some of these tools we're talking about would be really useful to help identify that, because it wouldn't be cheap, a heart failure poly pill.
Well, everyone, thank you. Let's thank Dr. DeLemos for running the talk. Again, thank you to Jane and Larry and your family for being such an important part of our society here in our organization. Look forward to the second one. Thank you. Yeah, I mean, the question I think we could spend maybe a couple drinks over HA or something we're talking about is, I mean, I'm pivoting my career a little bit more increasingly to trying to think about how do we test, how do we actually do randomized trials of what you've done. And I think you suggested one example, but I just it's going to be critical, I think, to move us to that targeted population management pathway to have that level of evidence beyond the science created to really kind of drive.
Yeah, yeah, I've thought, yeah, no, we've.
That's really, I'm thinking like, how am I going to pivot? You know?
Good, Christine. Yeah, but you know, I think those would have to be really pragmatic,
Yes, it's really
you know,
pragmatic,
and
yeah.
where you know, maybe
testing
done,
those,
maybe not done in the US because we need endpoint follow-up.
Right.
Because but you could do this in a health system, like you could just, without consent, you could randomize people, rather, you know, you could easily do a pragmatic randomized trial. And then if you had a way to track, you know, where you know, but it would probably, you know, we are testing like Ambrish is like, he and yeah, but Ambrish, but he's doing some EMR based RCTs of, you know, sending out, they have a risk score for incident heart failure and diabetes in there. So they're using, you know, the EMR to randomize patients to information provision. And then the recommendation is if their initial score is higher than X, then they recommend getting a troponin and a BNP. You know, so these sort of zero cost AB type trials to see if you, and then you know, the first steps of these are just to see if you actually change physician behavior, and then, but. You know.
Thanks so much for excellent.
Oh, awesome.
So I take him now to my office.
Yes, and
with Larry.
With Larry. So then there's like a schedule right after of, and they're all like within day, not week.
Okay.
So it's
I
going to
think
be
Nihar
Nihar,
takes it.
Erica, and then and there's a window when Larry can see him one-to-one again at around 11.
Perfect.
And then 11:30, I think there's one more. Jeff Testani's in the window somewhere. Right. And then Bell's also one.
Right. Okay, great. Well, thank you so much.
Thanks so much.
Thanks for.
When you're ready, I'll take you up.
Oh, thank you. Hey. Oh, thanks.
You all said it well. I mean, it's Larry's phenotyping from ECG, coronary angiogram.